Nurse Converse podcast. It's such an honor that you guys voted me to be on here, and I am beyond excited to have my very first guest today, which is somebody who is very near and dear to my heart, Sharon Hansen. Sharon is actually the very first nurse educator that I had straight out of nursing school. I was a nurse for about 5 minutes, and Sharon came into my life and has been a huge influence. She's been a nurse for almost 38 years. So I wanted to bring Sharon on today to talk about some really tough topics and some really topics that are near and dear to, I believe, every nurse's heart out there. And I am so excited to have you on, Sharon. Thank you so much for being here today. Sharon, 38 years, almost 38 years as a nurse. Right. And you are, you deserve an award. And I want to add to that, guys, that Sharon is actually bedside, still has gone all around, but has found herself back at the bedside for nursing. And what an accomplishment, night shift bedside nursing here. So if you're driving or you're just sitting around, I feel like we need to give Sharon a quick hand of applause on that one. So Sharon, I want to just hop in and kind of let everybody know why we decided to get together and do this podcast. And it was, Sharon has a passion for nursing. She has a passion for nurses. I do as well. And we had talked about the vulnerability that comes in nursing, the tough times, the humanity that comes in nursing that I don't think we address enough in nursing today. I don't think that we address the struggles that nurses face outside of the hero term that we so lovely got during COVID, that we're human and we deal with a lot of things in our profession. And knowing from what I know 10 years ago when I met you and watching you as your career and finding your story, I believe that you have a lot to teach us about what it's like to have trials and errors and adversity and be vulnerable in nursing. So let's dive into that. But I want to start, let's start with asking, how did you get started in nursing? And tell us, everybody hears about that dreaded first year. Right. Tell us a little bit about that.
So I planned on being a forest ranger. That was my, and I was backpacking in high school, and they were laying off forestry folks. And I thought, I'm toast. I have no idea what I'm going to do. And one of my family members said you could be a secretary. I thought I'd be fired in a hot minute as a secretary. So I felt kind of at loss. And then I came across a book. It was written by an ICU nurse telling her story. And I thought, I could totally do that. And then I was, I just kind of set my course there and moved from Minnesota out to Washington State, went to Pacific Lutheran University. Amazingly, in my mind, it was like, oh my gosh, I got into nursing school. And it was grueling and amazing and wonderful. And came out, I always wanted to be a pediatric nurse. But we each have our own insecurities. And I was offered a job where I precepted. It was an adult ICU. And I thought, I should take this because I don't know if anybody else would hire me. And so I did. And I started out there. It was a small hospital. It had a little, I think, 8-bed, 6-bed, 6 rooms, 8-bed unit. 6 of the beds were ICU, and then they had this little telemetry room. And I started out, and it was terrifying. I had this amazing charge nurse on night shift, Betty, and she was my right-hand person. And then 2 months into it, she moved. And it was me as a completely naive 21-year-old with absolutely no clue what I was doing. It was me and agency nurses. And I was
not too different from a setup a lot in today's hospitals.
I was terrified. I had no idea what I was doing. And then there were two agency nurses who felt pity on me, and Ron and oh my gosh, I'm blanking on him. I'm so sorry. Ron, and then this other nurse, it will come back to me, who literally they signed up to work with me on my shifts so that I wouldn't be alone. And they were really experienced. They worked up in Seattle, and they taught me so much. So
Oh,
so
that's
that
a,
yeah, yeah,
what would you say in that first year when you were going through it, so that some of our new nurses out there, what do you think was the toughest part of your first year in nursing? And mind you, this is almost 38 years
Mhm.
ago, and we do face some new challenges, especially post-COVID, but give us an idea of what you think was one of the toughest challenges that nurses now are facing in that first year.
I think not knowing what I needed to know. And the challenge is you go through nursing school and it's very broad. It has to be really, really broad. It's not focused. And I did get to take some coursework, and some of the nurses who taught that actually became my mentors through the years. Like Carol Jacobson. I mean, amazing to be able to learn from her. But I didn't know what I didn't know. And there were so many times where I was like, oh, I'm never going to forget that. I, you know, and just, you know, I would love to say I waltzed in and did amazing and everything was perfect. And I was this fabulous nurse. I totally was not. And I remember just thinking, dear God, they're trusting people's lives in my hands. I mean that, and I would go to work feeling like I was going to throw up. I would leave feeling like I was going to throw up. And there was a culture there. The hospital is no longer in existence for variety of reasons, but there was really a culture that permitted naughty behaviors
Mm.
in the from physician and just I mean I can't really say the whys, but I felt very vulnerable, and I had nightmares. I knew I had made the wrong profession, and there was a physician who was intimidating, but also inappropriate. And you know, you go report the behavior, and it's like, well, you know, they bring in a lot of money. You just have to put up with it. And when that was told to me, I thought, I have to leave. And so I fulfilled my contractual 1 year, and then left. And I mean, I was having nightmares. I had recently gotten married and was in the car. I'd fallen asleep. I'd worked nights and fallen asleep. My husband was driving. He got out to get gas, and the door little buzzer went off, and I flipped. I thought I was trying to get to a code and couldn't get out of my chair. And I thought,
Oh my gosh.
that's when I am done. I can't do it.
It's
And
enough. Yeah, you've
yeah,
had enough. And
yeah,
I can speak because you were with me in my first year of
yeah.
nursing, and there were times, and you would come on the unit and check on us, and to know Sharon managed a group of nurses, and we'd all kind of had our units, and it was at one specific hospital, which I'm so thankful for that hospital and how great it
Yeah.
was. And I had great managers and great people. Like Timmy Trust was somebody that I absolutely trusted. But I would, maybe 3 or 4 months in, we did residency, and Sharon would come and pop up and check, and I would see her, and I'd almost get tears in my eyes because I would see you and just the kindness. And it was so hard. That first
Mhm.
year, there were days I had to leave. I was sick.
Right.
How you entrusted these people high risk medications and drips and codes, and being a brand new nurse in the hospital that we were at, it was a tough hospital. It was
Yeah.
not an easy
Yeah.
hospital. I'm beyond thankful for that experience. It
Right.
set me up. But if there's any new nurses out here listening to this, and this is your first year, you are not alone. You have a
Yes.
38-year veteran, and you have a 10-year veteran telling you you're very much in that feeling is it's tough. And if it was easy, if you were able to
Mhm.
skirt into work on your first year and uh, this is all easy, I'm able to handle this, it would draw some questions because
Right.
you are responsible for those people's lives. And we should have a healthy sense of caution and I hate to use the word fear, but caution. So, which is such an interesting point that you come to that, you've learned a good lesson, and then you moved on to a teaching role.
Yeah.
And you've told me that you got your teaching wings. So tell us a little bit about how you transitioned from that bedside role to the teaching position.
Yeah. Well, and part of it, so I left that hospital, went to another hospital in the area, and the staff, they embraced me, and they were going on a whole, like, we won't tolerate bad behaviors. So they really created a very safe environment. And I was still on night shift, and it just was very much a learning. If we had downtime, the books were out, we were looking at things. So the nurses that I was blessed to work with really challenged, what's going on, and the physicians were safe to challenge. I had a CNS, not I had her, that we had a CNS, and she,
it's okay. I claim you, Sharon. I claim you. You're my Sharon.
Yeah, there we go. And I was very verbal, and I learned best by teaching. And Gail recognized that, and she was doing a skills day, and she said, "Well, I need somebody to teach the 12 lead station." And I'm like, I don't know 12 leads, but okay, I like to talk. So she sat, she gave me a study book, and I started looking at it, and I really, I have this ability of taking, at least in my mind, complex subjects and make them really simple. And maybe that's just how my brain works. But so I looked at the EKGs, and it's like, okay, how am I going to remember inferior? How am I going to remember this? And in all honesty, just sitting there teaching senior staff the 12 lead EKGs. And as I taught, I really started to get ownership of it, and just the support I received from the staff. And then I was given the permission to start developing content to teach. And so I would just start doing it, because if I could teach it, I could learn it. And I had some cardiologists who worked with me who really, we'd sit down, we'd look at EKGs, or we'd look at hemodynamics, and they really taught me. And the same thing with our pulmonologists, and then, of course, our clinical nurse specialists. And then I took ACLS. I had taken it several times. And one time Gail tapped me, and she goes, "What about being an ACLS instructor?" And that's really where I got my practice wings for teaching, and got to learn what worked, what didn't. And so, I started teaching ACLS, and then we were part of a Seattle consortium, and then Gail was transitioning what she was doing, or maybe it was Chris. I don't know, but they were transitioning. And they said, "Hey, why don't you teach hemodynamics pharmacology up for the Seattle Consortium?" And this was the consortium that taught me back in '86. And
full circle.
So it really was. And so people were kind enough to let me practice. And I was teaching, I had my little pointer, and I didn't realize I was blinding people with my laser, as I'm doing the slide advance. I mean, it's just like, I did so many stupid things, and yet people were so gracious and give me that chance. And I think that's one of my big takeaway is you have to go into nursing with humility and humor. I mean, I don't know how else to do it.
Absolutely true. Absolutely true. I love that you say you have to go in with the humility and the humor. That oftentimes they go hand in hand for a lot of the things that we end up doing and the mistakes that we make. And this is a great part where I want to talk about one of the greatest lessons you ever taught me. And this is a tough one. And this is something that I will carry with me forever. And for all of you listening out there, this is going to be your first fear. Yeah. It is your worst fear realized. And it's something that happened to Sharon that it's our worst fear as we practice. And when she told me this story, she told everybody this story, and she tells everybody in the new nursing. And I'm going to lead it in there, and she's going to tell it. And then I'm going to let you know how it has affected me and how I have carried on your words of wisdom and that experience to guide other nurses. So, fatal med errors happen. We are human, and let's start this by saying that at the end of the day, we're human, and we do not have a normal job. We do not go into an office, and this is not to mean anybody in office. I do that job now. However, when we go to work, it's not that we mess up a spreadsheet and some people don't get paid. We are in charge of people's lives. In the same sense, we are human. We are just as human as everybody else, and we make mistakes, and we're entrusted with things that are so incredibly hard to deal with, including human lives. And to expect us to be perfect on everything is just inhuman. And so you had an experience with a med area, and I'm going to let you take that away now.
This is, I've kind of tucked it far away until Jana, brought it back out. So thank you, Jana. No,
I'm so sorry.
This was really pivotal in my life. And I've had a few pivotal moments in nursing. This is one. I had and I'm not saying this to give excuses, it's just context. I had a friend who had just had a double mastectomy, supported her, and then went to work. They were short-staffed over the weekend, so I did 16-hour shift and then came back the following day to do my next regular shift. I did 12 hours. And I was actually on day shift then that was my scheduled shift. And it was super busy. We had old pumps. They were the little dials that you had to click in and adjust the medication rates. There was no smart errors or smart pumps. We had to do all the manual calculations and then dial it in. And then the other fun thing with this pump is that some had decimals, some did not. Okay.
Wow.
So wow. I was going between room to room, and I had this gal who was, she was at end of life. And I think, in some ways that gave me the ability to keep walking. I think if her story wasn't the same, I don't know if I could have kept walking, in all honesty. And I had gone in her room. My intent was to titrate down dopamine. I didn't full on look at the pump and thought I had decreased it to a rate of 9. What I had done, though, was put it to a rate of 90. And she went into VFib, and we coded her. And I was on one side. My friend was on the other side. We had stopped all the pumps because we were doing a code. And then she looks back at the pump and she asked me the question, and I about passed out right there. It's like, yeah, I did it. It was supposed to be at 9. It was supposed to be at 9.0. But with the pumps being different.
Right.
And again, I'm not excusing it. I look at what happened. I was tired. I was stressed. I wasn't 100% on, and I was going fast. I look at that, and that's what it was. And so we stopped, and the code was called. She did not survive. She actually had a large clot in her ventricle, and she her guardian or power of attorney wasn't able to make a yes or no decision of what to do. But what happened after, I'm so incredibly grateful for. The hospital leadership, my unit leadership, my physicians. We had the big meetings, the big quality meetings. And the ask was, would you tell your story? And the other thing I don't know what we called it then. but equivalent to a root cause analysis. We started looking at our pumps and how unsafe they were, and that it just was so unsafe. And so from that moment on, those pumps went away. We brought in one of the first smart pumps, where you had to, it certainly wasn't anything that talked to a computer, but you had to go in and some of the things were pre-programmed. You'd have to select concentrations, but it built in that little bit of safety net. And there wasn't that little clicking dial. So, positive things came through that. I'd be lying to say I didn't have nightmares. I'd be lying to say I didn't know if I could go back to work, but my workplace made it safe. And my colleagues made it safe, and the physicians made it safe. And that was such a huge gift. And so I kept that commitment. I kept that commitment when I taught the residency, because I taught hemodynamic pharmacology up in Seattle. I taught it for the system that I work for. And every time I taught it, I told that story. And, by the grace of God, we go every day. And I think the times when I look at even currently, when I rely on the story somebody's telling me, like, hey, yeah, blood consent signed. Okay, right. I trust this person. It's like, oh shoot, where is the blood consent?
Right.
And when you're doing those double checks, when you're doing those handoffs, I would say absolutely pay attention. When you're checking TPN, when you're checking insulin. I'm now working pediatrics, so we check everything. But don't give yourself that permission to kind of zone out when you're being the double check person. And don't rely, even though it's somebody you trust, don't rely that what they're seeing is actual reality. I mean, those are my big takeaways.
I think the biggest takeaway from this is you just spoken to so many people out of this. And as a ICU ER emergency, there's not a nurse out there who has not been in that position, tired, overworked, running. Yes, we do have some things in place later on in this technology, but we have all been in your position. And there are nurses out there who have made the same errors you have. And you are so lucky and so blessed that there's something that you said you had people made it safe for you. And I hope that the nurse managers and the administration and the people who are responsible for the nurses who are taking patients' lives in their hand, I hope you're hearing Sharon's story. I hope that you're providing a safe place for the nurses to come and to say, I've made a mistake. I need your help. I need your help. And this is where, Sharon, we talked about this, and this is one of the greatest gifts that you gave me in nursing, and that you're giving everybody listening to you, is the permission to be vulnerable. This permission to be vulnerable, because that's what nursing is. Not everybody can be vulnerable. And most of us in this profession, we're here because we are vulnerable. And that's a gift. It's a gift. But I want to say that when you Google it and you look it up online, that vulnerability can be classified as the quality of being easily hurt or attacked, uncertainty, risk, and emotional exposure, and even a weak point. That's what it can be defined. But Brene Brown, she's the queen of vulnerability. She's fantastic. And she said something that just makes me think of you and the story that you've told. And I really hope that anybody out there who has made a med error, or I promise you, if you stay in nursing long enough, you will make a med error. It will happen to you. I want you to think that vulnerability can also mean the willingness to show emotion or to allow one's weaknesses to be seen. Brene Brown herself said that vulnerability can lead to more open communication, and that people should have the courage to say, I need help. And that's what you've done, Sharon.
Yeah.
And I think that by telling your story on here and how many times you've told it, it's allowed me to be more vulnerable. I have made a nearly deadly med error myself. and I had to be responsible and own it. And it was one of the scariest moments of my life. And luckily the person was okay, didn't suffer too much damage. But I remember in that moment when it happened, my mind went to you, and I owned it. I was vulnerable. I took responsibility. And I, at the time too, was lucky enough that it was a safe decision. And I was
Mhm.
able to overcome it with the safety. So thank you for sharing that. It gets my heart here, because to hear that so many years later, there has been positive that has come
Mhm.
out of it, and people have changed. And even today, people are going to hear your story, and things are going to change. And there's going to
Yeah.
be a nurse manager out there that's going to have a nurse come to her, and she's going to remember you, and she's going to give her safety. So you are making a huge change in nursing by telling that story. And I just want to thank you for that. And
Thank you.
you're welcome. So, and I want to keep going, because Sharon, I could talk to her all day, and I want to go to this, keep going. And Sharon, I want you to tell us about, first off, Sharon is very, very educated. She was also another educator. She was an adjunct professor, correct me. It was at the University of Washington in
Mhm.
Seattle, UW.
All right.
And
Actually, Tacoma.
Tacoma,
Yes.
yes,
Yeah.
UW Tacoma. And she taught a clinical phenomena class.
Yeah.
And I want you to tell us what your favorite class was to teach, or your
So
favorite topic.
yeah,
Yeah,
no,
topic.
and the class was designed by kind of my nursing hero, Sharon Gavin Fott. She developed the class. She's actually developed tons of trauma stuff, and it it was where we took a look at certain human responses, and the challenge was to look at physiology and how to recognize decompensation and compensation. And then we looked at how that physiology would also tie into the experience and the behaviors that we saw. And originally, the students were writing papers, and I had so many papers to grade. I thought this is, and so I sit down with Sharon, and she's like, just how do you know that they have the concepts? And I had watched an instructor from Madigan do a concept map. And I thought, you know what, that's what I'm going to do. I'm not going to grade grammar, but they're going to do pictures. And initially I had it as individuals doing it. I thought this is great group work. And so I pre-recorded lectures and then would have the students come together, and on big old flip charts, they draw it out. And, what is my favorite? I think one of my favorite ones was when they were doing the cardiac, and and they drew out, the cardiovascular pathophysiology, and then how do you know when somebody's no longer compensating? And so they'd have to describe that, what they saw physically, and then describe what it looked like when they compensated, described what it looked like when they started to decompensate. And we talked about how do you recognize when somebody's tiring, and then what sort of behaviors, that restlessness, or picking at things. And a lot of times they would say, well, anxiety, well, that's an experience. What does anxiety look like? And so really diving into, so when you walk into a room, your doorway assessment, what do you see? And watching them then take that and look at the patient's positioning and all of that, and then what was the patient experiencing. And the fun part is I had people from the behavioral health, I had pediatrics, and so the different things that they brought into each group was really, really fun. And then we did like a picture show, and everybody would walk around, look at each group's uh, art per se, and they'd have to describe what they saw, and that was I heard again and again from students what a big impact that made, and so I think honestly all the phenomena were really fun, but that has been flat out my favorite class to teach in nursing.
Wow.
Yeah.
Sharon, and Sharon and I agreed that we were not going to script this. We had a couple topics, and we wanted to go back and forth. And that's so funny that you mentioned that, because some of the topics, I wonder, Sharon, and if you could, like you said, you can look at somebody and assess the patient, see if they're
Mm-hmm.
decompensating.
Yeah.
In today's nursing culture and climate,
Mm-hmm.
do you think that you, as a trained professional or somebody with experience, could walk into, say, a nursing unit, look at a nurse, look at the unit, and
Mm-hmm.
decide if they were decompensating, if they were burnout?
Yeah. Yes. Yeah.
What would that
Absolutely.
what would that look
So
like from a
I
nursing standpoint?
I think the importance. So you're saying if I were to walk into a unit
Mm-hmm.
and
Yeah,
see healthy versus unhealthy,
yeah. What would that look
the
like?
thing that I would say is you're going to see something. In a sense, it's like a snap judgment. Okay,
Okay.
and so you always have to look at your assumptions and then validate it. So I may see somebody who is withdrawn,
Mm-hmm.
and the story I may say is they're angry when they're just thinking through, okay, I've got this to do, this to do, this to do, this to do, and so I have to make sure that what I'm seeing is actually validated, so that
Wow.
it's really easy to like there's a nurse I love her. And actually, I had a very similar nurse at another job uh, who saved my husband's life, right? But my first off impressions were, this is a really hard person. This is she is hard, and the person who saved my husband's life, man, she dressed me down so many times when I was a new nurse. She totally
There's
did.
always one on every unit. One on every unit. Yes.
and and you know and my story that I told myself was, ooh, this is somebody I've got to be careful around. And then that was my perception. But then getting to know the person, it's like, oh, you have a heart of gold. You're the
Mm,
you're the nurse who's going to go grab the bottle of hot sauce and bring it in to this, person who can't leave the hospital because of his chemo treatments. You know,
wow.
so I just want to say, can I walk in and see a dysfunctional unit? Yes, I totally can. Um, but I also want to be careful to validate what I see. Um, and
Very
and
wise.
and if I go into a unit and see what I would perceive as not functioning well, I'd see a lot of siloing.
Mm,
I would see that where people are not comfortable approaching physicians, like reporting changes because of fear of being reprimanded. People are not trusting what they see, and maybe they're not comfortable calling a rapid response because when the rapid response team arrives, instead of being supportive and curious, they're condescending.
mm,
So it's that culture of not feeling safe. The other thing, yeah, so I think silence, and there used to be years ago this whole campaign on silence being deadly, and I think it still is. When
absolutely.
you see units that are set up structurally so that staff can't talk to each other, there was this whole movement to take nurses away from the nurses station because they're just going to talk too much. Well, what I think people outside of nursing may not understand is that talking is actually how we can share information and learn and grow. And,
Absolutely.
that safety to be able to say, can you look at this patient? I'm not sure I see what's happening. Um,
Absolutely.
you
That
know,
great. I love that insight. To hear you say that your perceptions in here, you have to validate what you're seeing.
mhm.
You've just carried so many wise sayings through here. And I love how you're saying the culture of the unit, the safety, being able to go and talk to somebody and say, I feel like this is what's going on. You've got so much wisdom, Sharon. And with that, you brought it up about your husband and
Mhm.
how nurse saved his life. I want everybody to see that Sharon from the bedside, but Sharon has also been on the other side of the bedside. Her husband, Sharon, was actually involved in the Sepsis Alliance and huge sepsis advocate, can speak everything you need to know about sepsis. She is an absolute expert on it. And then your husband got sepsis.
Yeah.
So tell us a little what that looks like, being the nurse as the expert on the other side, where you are the advocate, your husband's advocate at the bedside.
Well, and one of the things that Mark would say, my husband, is that I became an expert, and I don't feel like an expert anymore. I'm just going to put that out there. It's
wow.
Pediatric sepsis is so different than adult sepsis. So I feel like I'm kind of, wow, there's so much to learn.
Uncharted territory. Yes.
But really, so Mark had his encounter with sepsis back in 2003. And it was just becoming really identified as a syndrome around then. And I didn't fully grasp it, but then reflecting on our journey was like, oh, this is what we're talking about. And so I do really feel like I learned so much through his process. And I feel like if I could go back and have gone through that situation again, not that unfortunately we did have to go through it again, but just how much more prepared I would have been. Because there was things that, so Mark he was born with a bicuspid aortic valve. He ended up getting strep. The strep wasn't, he was treated with antibiotics. His presentation was weird in that he had a lot of neck pain. He'd go on antibiotics, he'd get better, go off antibiotics, he'd get worse. And it took months to actually get a diagnosis. Wow. And by the time he ended up becoming really sick, his mitral valve, his aortic valve were gone. And the challenge was he was able to sit up and be fine. When he laid down, he wasn't. I was taking care of my mother-in-law. She was going through her cancer treatment. We had 4 kids, and I was working full time. So I was like, I didn't recognize his deterioration.
Wow.
And part of it was he could compensate so well. I mean, he went to the job site before his echo, the morning before his echo.
Wow.
And then when he laid down, because he had been just sleeping in a chair, saying that, it just made his neck better. So he would sleep in a recliner and do fine,
Right.
And then when I saw him lay down for his echo, it's like, oh, this is not good.
And you're nursing, you're taking care of kids, you're doing a full-time nursing job. And we all know nurses, we don't really vacate our role when we're at the taking care of a loved one. We're always still a nurse. And how did that feel to come to that realization that I've missed this? This is something we hear about a lot with, we do it all the time. I've let my kids walk around sick is sick because we don't go to the ER unless the phrase is always, we're not going to the ER unless you're dying. And every nurse out there, that's what you tell. We don't do that. So how did that change? What did that feel like?
It honestly, after the whole ordeal, and this is where I would say that nurse literally saved my husband's life. When Mark got admitted, she recognized, she got the team there, got him intubated. I mean, she just stepped in and did phenomenal. I had a really hard time going back to the bedside, to be honest. And I did it, but it was challenging, and that's where it was really quite a gift that our CNS asked, "Hey, do you want to come help with teaching?" And so I was able to start kind of doing part-time patient care, part-time teaching, and that helped me kind of decompress a bit. And I just remember our one of our pulmonologists, one of my favorite ones, was saying, "Wow, you've really lost your edge." Yeah,
Mm.
yeah. I lost my edge, and I went from because now I understood what it was like to be a family member.
Mm.
Now I understood the unknowns, and now I understood that I might not pick something up.
Wow.
Now, I did pick up, because I learned off of Mark. I did. There was some, he's got 2 mechanical heart valves. I did learn, somebody with lung cancer who she has a mechanical heart valve, and I'm assessing. It's like, I don't hear the click. And, yet she's on Coumadin, and we were able to get an echo. And yeah, she had a big old clot in her ventricle.
Wow.
And the cancer had bypassed the Coumadin basically in the clotting scale.
Wow.
So, I mean, there were things that I was able to take assessment skills from that brought my teaching to a whole new level.
Wow.
But I did lose my ability to be, okay, game on, they're coding. Awesome. Let's go. I don't have that edge.
Yeah.
Nor do I want it.
That's completely understandable. It's almost, I wish I could quantify that statement or qualify it, but I know what you mean, because it's the same with me working in emergency and trauma and critical care medicine. I think it's an unspoken between a lot of nurses, especially ones with experience out there. You lose that edge and you don't want it back, because you know what comes with the territory.
Yeah.
And that's the hard truth of nursing. That's what we have to talk about in nursing, that sometimes that adrenaline is fun in the beginning, and then it doesn't become fun, because I almost think we see what's on the other side of that. We see the pain and suffering on the family side of it. We know what it does to us when we have to go home and carry what we've just done during the day to bed, and we have to sleep with that. And then I almost would want to say that losing your edge sometimes means maybe we're finally realizing, especially for us ER nurses, we have a heart, and that's tough. And that's because we have to get past that to do our job. And I can tell you just from experience, one of the very last babies I coded, I lost my edge.
Yeah.
I didn't want to do it anymore. This is not something that anybody was ever meant to do. As far as mentally, it absolutely takes its toll on you, and it causes bitterness and burnout that we're all experiencing. And it'd be one thing if it were the job and we had safe places to go, but that's just not where we are in nursing right now.
Right.
So, and it's a sad, but I do want to kind of start going toward where I think this just really gives me a lot of hope, and I think it will other people. You went back to a nurse residency in the PICU. After years and years.
I did.
And but it didn't go. And like Sharon says, this was a right bus, wrong seat situation. And this is going to speak to a lot of people out there right now that you're trying to figure out, I don't know what I'm doing in nursing. And I want us to kind of gear this over to everybody out there who's, you guys are talking about all the fun things in nursing. So what can we do in nursing? And tell us how you got into this residency and where you're at now.
So I always thought, I was a critical care educator. I love critical care. I love hemodynamics. I love ventilators. I love dialysis, all of it. And I thought, well, shoot, I'm going to just go into PICU. And the other thing that's, this is kind of dumb, but I never thought I would do okay in med surg. Not because I am so focused on one patient, or so like if somebody's talking to me, I'm all there. And I was like, good Lord, how am I going to do 5 patients? And so when the choice came, it's like, well, I can't do med surg. I'd be a disaster on med surg. So, PICU it is. And the challenge with PICU, and again, I'm not making excuses, but it was during COVID. And there wasn't a lot of patients. Maybe it would have made a difference. I don't know. But all I know is I was not fast enough. Like I said, I had lost my edge. I didn't, pediatrics was mind blowing to me. The things that we see in peds, we never saw in adults. I mean, it was either fixed or not fixed before they came to adults.
Wow.
And there were just concepts I could not wrap my mind around. And so they extended me. It was humiliating as all get out. And especially since I taught some of, I taught. And and then, I remember having a meeting and just looking at the manager, somebody I really respect, or director. And I just said, she would say, well, we could extend you again. I said, why are we beating this dead horse? It's not, what is going to change? Nothing is going to change. This is not a good fit. And the times they would have me go work on our med surg unit, I loved it. It was like, oh, this is so cool. And so somehow the med surg manager was willing to take a risk on me. And I was like, well, this is it. I don't know. Maybe I will go into forestry now. So I went to our med surg unit, and I was met with the most, I've worked on really great teams. So I don't know if I can say this is the best team ever, but I will say this is this is the best team I've ever worked with. And I'm not saying that to diss my other teams I've been a part of. They were, and they still are, phenomenal. And to have a unit this big, this busy, and to have a leadership team that listens, and to have a leadership team that allows the bedside nurse to take initiative and change process is phenomenal. And the other never that I had said, so I'd never do med surg, right? And I would never do oncology, never. And it was part of the requirement of the job. And started doing hemonc for pediatrics and fell in love with it. And I think that's my takeaway is, be open.
Yes,
just
absolutely.
be open, and go into something with humility. I mean, it was so humbling going there and say, yep, I got voted off the island.
Oh my goodness.
And that's still what I say, because it's true,
It's so true. I could not agree with you more, Sharon. And you just listening to everything from here. I know you, and I know some of your story, but hearing you tell it and knowing that there's going to be so many people that are going to resonate with you, it means so much that you've been so vulnerable to come share your story. And I want to wrap up with this. If there was one thing that you could go back and tell yourself coming in as a nurse that you can share with our new nurses, as well as give some encouragement and hope to veterans nurses out there, what would that be, Sharon?
I always go back to be teachable, be coachable, be curious, be humble. It is such an honor to meet people at their level of vulnerability. And something I would tell the residents that, if we were to do the things that we do as a nurse to somebody on a street, we would be arrested.
It's
And
so true.
and we have to have that reverence. It really is a sacred trust. And the moment that we lose sight of that, um, it's time to evaluate what are we doing and why are we doing it, and is it time for a change? And
Absolutely.
that's the other thing is, you can do anything in nursing. You can
Yes.
do anything, and
Yes.
I missed bedside nursing so much.
Mm,
And one of the reasons I went back, the model of education, which it's working great. Okay.
mm.
It just wouldn't have worked great for me, but I would be farther from the bedside. And when I really, sorry, I'm like, I do have hand hygiene, available here. And
It's
so
okay.
I'm looking, shoot, I should have brought a tissue. Um,
It's okay.
the the model works, but it didn't work for me. And I knew that I had to get back to my passion, which was working with patients, which was working with families. And I really wanted to get back to kids. And so I never did it before. And that was my whole reason for going into nursing. And when I was getting, I hit 55, I'm like, oh my gosh, if I don't do peds now, I'm going to be retired before I do. And so I think that's, be open. And I think you have to evaluate, how are you doing? How is the job? Are you safe? Are you healthy? Are you remembering the sacred trust?
Mm,
And extending it to your patients, your families, but also your coworkers and yourself. I
absolutely.
so
That
that's what I would say.
Sharon, I could not agree with you more, and it's absolutely spoken to my heart. And I thank you from the bottom of my heart
You
from
bet.
being somebody who has meant so much in my career. And for you guys listening out there today, if you have somebody in your life in your nursing career that's been a mentor, I highly encourage you to reach out to them, give them a call, send them a cup of coffee, just a text telling them thank you for everything that they have done for you. So thank you, Sharon. And
You are so worth it. Thank you, Jana. This was so much
absolutely.
fun.
Thank you for coming on today. And thank you all for listening to this episode of Nurse Converse. And everybody, stay safe, stay vulnerable, and take care. Have a good day, guys.
Bye bye.